Welcome to AETCM, the emergency medicine channel. A 62-year-old male came to ER with complaints of imbalance while walking since 2 days and multiple episodes of vomiting. On initial 10-second assessment, airway is patent, no pooling of secretions. Breathing, respiratory rate is 16 per minute, saturation 100% on room air entry bilaterally equal. Circulation, BP was 140/80 millimeters of mercury, pulse rate 68 per minute, all peripheral pulses equally felt bilaterally. Coming to disability, GCS were E4, V4, M6, pupils bilaterally equal and reacting to light. Coming to exposure, patient was afebrile and GRBS 100 milligram per deciliter.
So what is the primary complaint? Giddiness and multiple episodes of vomiting. So what are the differential diagnoses which you will have now?
Any posterior circulation stroke, BPPV, electrolyte imbalances, hypoglycemia.
Or any febrile causes. Okay.
Coming to sample history, a 62-year-old male, known case of hypertension, presented to ER with complaints of imbalance while walking since 2 days. There were multiple episodes of vomiting and slowness while walking since 1 day. It was insidious in onset and gradually progressing in nature. He was subsequently evaluated at a local hospital with CT brain which showed a left fronto-parieto-temporo-chronic SDH with maximum thickness of 20 millimeters and midline shift of 12 millimeters. Past history, patient had a alleged history of RTA 2 months back, self-fall from two-wheeler, following which he was evaluated at a local hospital and was managed conservatively. The CT brain then taken was normal. Then we had taken a VBG.
So suppose this patient presented at that time with a history of RTA. What is the age of the patient?
62.
62-year-old. So 62-year-old male patient came to the ER with complaints of an RTA. So what is the indication for taking a CT brain?
There are two new rules for the decision rules for CT imaging. First is New Orleans criteria and another is Canadian CT head rule. New Orleans criteria, the criteria are headache, vomiting, age more than 60, intoxication, persistent anterograde amnesia and evidence of trauma above the clavicle and seizures. Canadian CT head rule, GCS less than 15 at 2 hours on assessment. Suspected open or depressed skull fractures, age more than 65 years, more than 1 episode of vomiting, retrograde amnesia more than 30 minutes, dangerous mechanism, this patient is either thrown out of the vehicle, then any signs of basal skull fractures.
Okay. So basically difference between New Orleans criteria and Canadian CT rule is mainly most of things are similar, but major difference in New Orleans criteria, they will mention about if there is a presence of headache, they will ask to do CT. Then any intoxication, if it is suspected, they will ask to do CT, and any injuries above the clavicle also. Then based on children and adults, how will you decide CT?
Mechanism dangerous. I mean mechanism of the trauma.
What is a dangerous mechanism?
In children, fall from height above the height of the child.
Above the height of the child, or if it is staircase, more than 3 staircase. Adult,
it may be if the patient was thrown away from the vehicle.
Twice the height of the...
twice the height. We can, if it is falling from stairs, in children more than 3 stairs, an adult more than 5 stairs, or 1 meter is considered as dangerous mechanism of injury. Then other dangerous mechanisms, as you told, ejection from a vehicle. Then
high velocity,
high speed, high velocity trauma. High velocity means beyond what?
50 kilometers.
Beyond 40. Then roll over. Then any accidents during any recreational activities, that is considered as high dangerous mechanism of injury. Or any fall with an fall of something onto the head, or any axial load coming. These are considered as dangerous mechanism of injuries. Okay. Then other differences, adult and children. So in adult, if a patient comes to ER, CT depends on few of the things. So if an adult is presenting to the ER with complaints of any focal neurological deficits, then we will have to consider doing a CT brain play. Any more than one episode of vomiting, a CT brain play, that too CT within 1 hour of presentation. Any more than one episode of vomiting, focal neurological deficits, then any seizures, then other things.
GCS.
Low GCS. So beyond what GCS will you consider CT?
Less than 8.
So if the patient is coming to ER with the GCS less than 13, we will have to do. Less than 8, we have to consider intubation. So if the patient presentation GCS is less than 30, then you will 13, you will have to consider intubation. And if the patient has presented to ER with a trauma more than 2 hours and the presentation GCS or the patient's GCS is worsening within 2 hours to less than 15, then also you will have to consider CT brain plane. Then any features of base of skull fracture. What are the features of base of skull fracture?
Any CSF rhinorrhea, portorrhea, bleeding from nostrils and ears. Then any contusions.
What is that? Battle sign. Raccoon eyes. Okay, that and any features of base of skull fracture. Okay, so GCS criteria we have told. Then any fracture, base of skull fracture or any depressed skull fracture. Then vomiting, focal neurologic deficits and seizures. So in these cases we will have to consider taking CT within 1 hour. And some additional thing is based on age. If this patient is 62 years, if a patient is coming with an age more than 65 years and who is taking any anticoagulants like warfarin or any antiplatelets or any bleeding abnormalities, then also you'll have to consider taking CT. Then comes the dangerous mechanism of injury. Then comes the any patient who is coming with the retrograde amnesia more than 30 minutes. That is also considered. So in this patient also we'll have to consider CT within 1 hour. Rest of the patients we can monitor based on the, if it is coming as a borderline indication and all, you'll have to monitor and we can plan a CT within next 8 hours. Whereas if you come to children indications grossly same only. But if the child is more than 1 year, presentation itself, if the child's GCS is less than 14 in a child who is more than 1 year, and if it is GCS is more than less than 15 in a patient who is less than 1 year, then we will have to consider doing CT brain play. And adults vomiting more than 1 episode is an indication for doing CT. Whereas in children, more than 3 episode is considered as an indication for doing CT brain play. And in adults, one thing we told is retrograde amnesia. Retrograde amnesia beyond what is will you do CT? 30 minutes. In children, retrograde amnesia more than 5 minutes or a loss of consciousness more than 5 minutes. Grossly these are the difference. So retrograde amnesia more than 30 in adult and in children more than 5 minutes. And if there is an LOC more than 5 minutes in children, or if the child is showing any abnormal drowsiness or drop in GCS. And a child, whenever you are suspecting any non-accidental injuries like an assault or something at home, or any you are finding some features of any different ages of injuries if you are seeing, or if you are seeing a child with abnormal bruises or laceration in the body, then also you'll have to do CT immediately. Okay. So this patient initial CT was normal, later on developed drowsiness, and then CT was done. It is showing acute and chronic stage. Okay.
We had taken a VBG. It showed no acid-base imbalances. Sodium was 125, lactates 1.1, and we had given Levipil 1 gram IV as a prophylaxis, and mannitol 0.25 to 1 gram per kg was given. Then we had taken a CT brain.
Why this Levipil and mannitol was given?
Because there was mass effect. Midline shift was there, 12 mm.
12 mm midline shift is there. So what is the indication of giving a Levipil and mannitol?
If there is mass effect is there.
In the mannitol, usually it is preferred only if the patient is herniating or if there is any chance of herniation. This patient is having only midline shift, didn't start herniating, and this is elderly individual. Elderly patients will have more space in the brain. Patient might be having some brain atrophy, and also this point of time, no need to start on mannitol. Levipil based on patient's indication. If the patient is having a high tendency for seizure or already had seizures, then only the indication for Levipil is also coming. So this point of time, what is the initial action? What all things will you do?
Head and elevation.
Head and elevation.
We can start 3% saline
So what is the dose of 3% saline?
at 30 ml per hour. We can start this to make the sodium above 150. Keep
No need of more than 150.
145.
Between more than 140 to at least more than 145. Okay. In IC bleed, what is the 3% saline dose preferred? We can give as a bolus dose, 5 ml per kg bolus dose can be given, or if you are starting it as an infusion, you can give it as a 0.1 ml per kg per hour infusion. That is a dose of 3% saline. 0.1 ml per kg per hour. So mannitol and Levipil only if you are suspecting a seizure or patient already had a seizure, and mannitol only if the patient is having a drop in sensorium, any difference in pupil, or if you are suspecting a herniation features, then all are already herniated. In that case only you will give mannitol. What is the dose of mannitol?
0.25 to 1 gram per kg.
1 gram per kg. Okay. So this patient, ideally you could have done a head and elevation, you could have avoided necklines. Then if at all this patient was already intubated and all, you can prevent this tight neckties and all, because that can increase the ICP. Okay.
We had taken a CT brain. It shows subacute SDH in left frontoparietal convexity with maximum thickness of 19 millimeters, causing mass effect and midline shift of 10 millimeters to right. So we had done a neurosurgery consultation. They did a left-sided burr hole evacuation and post-op CT brain showing thin residual SDH with maximum.
So what is the indication for doing a surgical management in SDH? All SDH we won't be taking for a surgical management. We will mostly it will be conservative management. So what do you think the indication for this patient was?
There was midline shift was and there is a patient was symptomatic like imbalance while walking.
That is not indication. Only 5 indications are there. If a patient is coming with the SDH for surgery, only 5 indications are there. So this patient's what was the size of the SDH?
Maximum thickness of 19 millimeters.
19 millimeters. So any SDH more than 10 millimeter is one indication. Then midline shift, how much was it?
10 millimeters.
10 millimeters. So midline shift more than 5 millimeter is another indication. So size, so anyway this patient had 2 indications. One is size more than 10 millimeter is there, midline shift more than 5 millimeter is there. Then other indications are any signs of herniation, any asymmetry in pupil or something. Okay. Or if the patient presentation GCS was less than 9. Or while monitoring if the patient's GCS drops more than 2. These are the only 5 indications. So this patient met 2 indications. GCS was 14 by 15, right? So this patient had 2 indications. That's why this patient was taken for evacuation. So what are the signs of herniation?
Herniation, actually we have 4 types of herniation: uncal herniation, central transtendorial herniation, cerebellotonsillar, and upward posterior fossa herniation. In uncal transtendorial, it is the most common. In that there will be the parasympathetic fibers of the oculomotor nerves are initially affected. So the ipsilateral there will be a dilated pupil, fixed and dilated pupil, and later on the pyramidal tract will be affected. So the contralateral motor deficits will be present. And in central transtendorial there will be bilateral pinpoint pupil, bilateral Babinski sign positive, and increased muscle tone will be there. In cerebellotonsillar, pinpoint pupils, flaccid paralysis, and sudden death can occur in cerebellotonsillar. And upward posterior fossa, it is conjugate downward gaze with absent vertical eye movements and pinpoint pupils.
Okay. Anything else you want to ask?
What is Kernohan-Hodge phenomenon? Can you explain?
It is a false localizing sign. Actually, they may be ipsilateral motor paralysis can be present.
Usually, whenever there is a hemorrhage or any intracranial pathology, like suppose if the patient is having a left-sided hemorrhage, ED is like that, there will be left-sided dilated pupil. And gradually, if there is herniation in the left side, ungual or temporal herniation, that will compresses the corticospinal tract of the right side. As we know, there is crossover that takes place. So, whenever the right corticospinal tract is involved, there will be hemiparesis on the left side. So, if the patient comes with left side motor deficit, we will think the pathology is in the right side, but actually the pathology is in the left side.
Okay. So then what happened to the patient?
Burhole was done and post-op CT brain showing a thin residual SDH with maximum thickness of 4.4 millimeters with post-op pneumocephalus in left hemicranium, and patient was gradually shifted to ward, drain was removed, and gradually he was mobilized and discharged.
Okay. So so if a patient with SDH is there in our ED, okay, what is the management plan, or SDH or any type of intracranial hemorrhage? How will you manage in the ED?
The primary aim is to prevent the secondary brain injuries. Initially we have to give a head and elevation, loosen the head collars, and then treat the electrolyte imbalances and treat the hyperglycemia, and then sedation, seizure control methods can be done.
Seizure control with?
Levipil.
Benzodiazepines.
Then intermediate is mannitol or furosemide. Then paralysis, heavy sedation, CSF drainage by EVD. Then final is mainly induction of thiopentone coma and decompressive craniotomy.
So in our ED, the management is not like this. Our management is airway, breathing, circulation, disability, exposure. So airway, when will you plan on securing the airway?
When the patient has low GCS less than 8 or 7, or there is
less than 8. So this patient, how can you classify this patient's brain injury? Is it mild, moderate, or severe? Brain injury classification is based on GCS. So this patient's GCS was 40. So it is mild. Appearing as mild. Okay. So how will you classify based on GCS, mild, moderate, severe? If the GCS is less between 12 to 15, it is mild. Between 9 to 12, it is moderate. Less than 9, it is severe. That is the GCS based classification. So this patient, airway, GCS, if it is less than 8, we will plan on intubating. So what are the agents you will choose? If at all you are planning to intubate, how will you intubate this patient? What are the 7 P's of intubation?
That's the preparation, then positioning.
Preparation after preparation?
Pre-oxygenation.
Pre-medication. Pre-medication with?
We can support, we can start with IV fluids.
IV fluids. So we are giving an induction agent and a paralytic agent. So if we are giving an induction agent like etomidate or propofol and all, this might have pain. So we'll have to give a mild dose of opioids like fentanyl or something to reduce that. And if at all this patient is already having any midline shift or ACE ICP, we'll have to consider 3% saline mannitol, BP control. These things should be done. That is the pre-medication. Then positioning.
Placement.
Paralysis. Next is the induction and paralysis. Then is the placement of tube. After that, post-intubation management. These are the 7 P's of intubation. So, what all agents will you choose? Etomidate. What is the dose?
0.2.
0.3 mg per kg. Then what are the other agents you can choose? Why? What is the advantage of giving etomidate in a patient with IC bleed?
Reduces the ICP.
It doesn't have any effect on the blood pressure. Then?
Myocardial stability.
Okay. Okay, fine. What are the other agents which you can choose? Propofol. Why propofol?
IC pressure, decrease the surgical flow and decrease the IC.
Improves it.
Yeah. And it is having anti-seizure property. Then paralytic agents, acronium or succinylcholine can be used. Our aim in a patient with ICU bleed is to give a maximum smooth intubation as possible, because we don't have to increase, we don't want the ICP to increase. Already this patient is having raised ICP. So if we are giving a painful intubation to the patient by not giving adequate analgesic agent, by not paralyzing the patient or giving the paralytic agent, if you are immediately scoping, the patient might not have paralyzed. Such things will stimulate the patient and will cause high ICP. So we don't want that. So airway, that is the management. And how will you keep the ventilator setting? What are the ventilator targets? PCO2. PCO2 between 35 to 45. Then PO2. PO2 more than 60 should be there, and saturation also should be more than 90, because if it is coming down, what will happen? The patient is having a tendency to go into hypoxia. Brain will have a tendency to go into hypoxia. So, a ventilator setting should be in such a way that these parameters are reached. So that is airway and breathing. And if the patient is having irregular breathing, what will you suspect? Suppose airway we have Cushing's reflex. So what is the triad?
Increase ICP.
It happens in increased ICP, especially when coning, bradycardia, hypertension and irregular breathing. So that should be checked. Okay. Then circulation, what will you see? BP control. So what is our target blood pressure? So what is our aim in ICP? Will we aim a high BP or a low BP? So we don't want the brain to bleed again. So we will have to set a BP so that the brain will not, if the BP is again worsening, then the brain will bleed again. So that shouldn't happen. Whereas if the BP is too low, what will happen?
Cerebral perfusion.
Cerebral perfusion will get affected. So in such cases, usually what is the MAP setting which you will keep in a patient with sepsis? More than 65. But in a patient with IC bleed, we will have to keep a MAP of 80. That is required for cerebral perfusion. So what is cerebral perfusion pressure?
MAP minus ICP.
MAP minus ICP. So our ICP, what is a normal ICP? Between 15 to 20. That is the max. That is the normal intracranial pressure. So in a patient with intracranial bleed, ICP will increase. So MAP minus ICP is the cerebral perfusion pressure. So if we are not, if MAP is very low, then MAP minus ICP will be low. That means cerebral perfusion will be low. So we need to keep a higher MAP. That means 80 should be the MAP. So for reaching that MAP of 80, we need at least a higher systolic BP. At least, so according to textbook, it is said that any individuals less than the age of 50 years, we want a systolic BP of 110. Less than 50 years, 110 is the systolic BP. From 50 to 70, 100 systolic BP is required, and more than 70 again 110 systolic BP is required. So that means systolic BP is necessary. Okay. So less than 50 and more than 70 systolic BP is 110, and between 50 to 70 years 100 systolic BP is required. Then only we will be able to maintain the cerebral perfusion pressure. And if at all the blood pressure is increasing, what will you do? If it is increasing more than 140 and all? Labetalol. How much will you give?
10 milligram can be given to 6.
Always stat dose is 20 milligram you can give, maximum up to 200, even more than you can give. So labetalol is the preferred agent if the patient is not having bradycardia. Okay, then that is about the circulation. Then GCS monitoring. GCS you will have to continuously monitor. Then other things are in the disability monitoring itself, we will have to monitor the temperature and glucose. Okay, what is the glucose target? 140 to 180, that target we will be keeping, because hyperglycemia can worsen the brain. Hyperglycemia will have increased action in the brain, increased glutamine release and increased metabolism in the brain. That can worsen the brain. And even hypoglycemia will have hypoglycemic changes in the brain. So 140 to 180 glycemic control should be kept. And temperature control,
Prevent hypothermia.
Normothermia. In some studies, some in other countries and some areas in India, they practice hypothermic resuscitation of the brain. So that has to be proven. But our aim is to prevent fever and hyperthermia, because again, fever can increase the metabolic rate, that can increase the glutamine release in the brain, that can increase the pro-inflammatory cytokines in the brain, and that can worsen the brain's secondary damage can happen. Primary impact already is there, so secondary damage might happen to the brain, so we need to prevent that. And so temperature control should be there, and glycemic control also should be there. Okay. And suppose this patient, if you are monitoring and you are seeing any pupil dilatation, that much time patient's pupils, everything was normal, suddenly if the patient is showing features of coning, what will you do?
Can start mannitol.
Mannitol can be started. Decompression. For as a part of bridging for surgery, what else can you do? We are already head end is elevated. We are not planning to keep any tight neckties. No neckline should be there. That all will worsen the ICP. So that all things you need to take care. Mannitol you can give, and any change in ventilator you can make. So if you are feeling that the patient has herniated or any pupillary asymmetry you are finding, that time you can keep a hyperventilation can be done. Why?
Low PCO to low wire vasoconstriction of the cerebral vessels.
Okay, so if the patient is having a higher PCO2, the brain blood vessels will have a tendency for vasodilatation. So vasodilatation will worsen the brain and bleed and edema of the brain. So if you are hyperventilating, there will be vasoconstriction, and you can reduce the excess bleeding and secretion to the brain, but it will be done for a transient time only. All the cases we won't be doing. Only if the patient is showing some features of herniation, we will be doing. If you are doing unnecessarily, what will happen? If you are allowing for unnecessary PCO2 washout, what will happen? Perfusion of the normal area will get affected. So in herniated patients only, we will be planning to do this. Okay. And suppose we are taking it for surgery, what are the blood parameters should be monitored? HB should be more than 8. Platelet
More than 1.
Platelet cutoff for any IC bleed procedure, or if you are having a patient with a dengue fever with IC bleed, in such cases platelet should be more than 75,000 to 1 lakh. Okay. It should be there. And if the patient is already on any any anticoagulants or anything, and if the patient requires surgery, the INR should be less than 1.4. So this much things should be considered. Okay. Anything else? So what happened to the patient now? Did he improve?
Patient improved, mobilized, and then he was discharged.
Discharged. Okay. Fine.